I'm going to talk to you today about cardiac tumors and what's known and what's unknown in the world of cardiac tumors. Now you have to hold on to your seats because this is going to be an overall lecture right from benign tumors all the way to malignant tumors, what's new and what's unknown. And hopefully after listening to this, you'll realize that although we thought we knew something about some tumors, we actually know a little bit less than what we thought. And I'll show you why a international database is really important. The objectives of this lecture are to understand the current knowledge regarding benign and malignant tumors, describe the potential reasons for recurrence after myxoma operations, because they do recur, list the most common cardiac tumors in the pediatric age group. We'll have a lengthy discussion about that, and describe the shortcomings of malignant cardiac tumor treatments. And finally, as I said, understand the reasoning behind the INTERACT project. If you go back to all the lectures from the previous years, you'll realize that although we have world experts, there are some unanswered questions, and hopefully the INTERACT project will bring some of these questions a little bit closer to a reality. We will explore during this talk of myxomas, fibroelastomas, pediatric tumors, and malignant tumors, and we'll touch on whether minimally invasive approaches are important or recommended for cardiac tumors. First, let's start off with myxoma. Myxomas are the most commonly resected cardiac masses. You can see here how much more commonly myxomas are resected than any of the other tumors. Quite a lot more. It really is outstanding in terms of the number of operations performed for myxomas. For the malignant lesions, there are malignant lesions, and the most common malignant lesion to be resected is a sarcoma. This is a typical paper from China of 212 patients over a 16-year period. You can see there they resected 180 myxomas, and you can see it's by far and away the most common tumor they resected. With respect to the location, the left atrium, as expected, is the most common, with the right atrium and then ventricular chambers much less so common. Myxomas occur in all age groups, and you can see here 10 to 19-year-olds, there are myxomas. As a matter of fact, they start at less than 10 years of age, and they vary throughout the life of an individual. The female gender is more commonly afflicted by this lesion, and this is for an unknown reason. But they are tumors that span the whole life of an individual. Once resected, however, the lifespan of an individual equals that of a normal population. So just because you have a myxoma does not mean that your life is shortened. This is another paper spanning 56 years and 194 patients that were collected in those 56 years of myxomas. Some myxomas present as emboli, most commonly cerebral emboli. So neurologic events are sometimes the initial presentation of a myxoma, and it happens between 20 and 30%. This group, again from China, examined 162 myxomas over a 16-year period, and they found that 20% of their patients presented with an embolus. They tried to get some information as to what was it about these myxomas that made them different from the rest. And they tried a multivariate analysis of the retrospective data that they used. So you can see there are problems here. There are small numbers and the retrospective data. And they found 4 different values that they felt was representative of those patients who presented with embolization. They had a high platelet count, a greater mean platelet volume, an irregular shape to the tumor, and an abnormal location. So these are the risk factors. Now, a platelet count greater than 300 is reasonable. A mean platelet count, they didn't give numbers or anything like that, but remember they had small numbers. So they tried to, but again, with small numbers, make a diagnosis, and make a treatment strategy for those people. Let's talk a little about minimally invasive operation and recurrence. Are they related? There are many papers of minimally invasive approaches for left atrial myxoma, for benign lesions, but they're all small papers. And they all talk about benign disease and they all talk about myxomas. I'm going to talk about one of these just to choose one out of very, very many. And these people looked at 30 patients over a span of 11 years, and they used the shave of the myocardium or the base of the stalk. Now, I don't quite know what that means. Shave myocardium, I can understand it. And this is either at the base of the stalk where they took a scissors and cut the stalk off and left the base of the stalk attached, or they took a piece of myocardium along with the mass. It's hard to determine from these papers what exactly people do. They had 1 out of their 30 patients who had a recurrence at 24 months. This is obviously not the optimal outcome of a person, and you might blame the video assisted in the minimally invasive part, and they couldn't see very much. Perhaps they cut the base of the stalk and left the tumor there, so they didn't completely resect it. They may not have done a cancer operation. Open surgery must be better, you'd think. Here's a paper from the Mayo Clinic group. They found 194 patients in the 56 years, and these are their locations. The left atrium, as mentioned, was the most common. They found a few more in the right atrium and some in the ventricles. So whether the numbers are bigger or smaller, the ratio always is more or less the same, most in the left atrium and then in the right atrium. Their average tumor size was 4 by 3 by 2 centimeters in size. And you can see some of the reasonings for operation on these individuals. Now, in their paper, they mentioned that they cut the base of the stalk or they used an endocardial button. And when the tumor came from the intraatrial septum, they took a portion of the intraatrial septum as well. Unfortunately, it's a little bit hard to understand exactly how they took the tumors and when they did. But you have to remember, this is over a 56-year period. Coronary bypass has changed over a 56-year period. I think probably most operations in the world, including hernia operations, bowel resections, breast operations, have changed quite a lot in the last 56 years. So it's not surprising that cardiac procedures have changed as well. But you have to take this into consideration when you think about recurrence risk. So what was their recurrence risk? Well, they had 13 out of the 194 people that recurred. Interestingly, 9 out of those 13 recurred in the same location. And you can see the time. Now, they had a recurrence in a 12-year-old after only 1.2 years. And they had a recurrence in a 45-year-old after 26.6 years. So it's quite a long variation in terms of the recurrence risk. And there may be a difference in terms of the ages. This goes in an ascending order for ages. So they had 13 of theirs recurred, but when they recurred, they were in exactly the same location. If you remove the Carney's complex, now Carney's complex is a genetically predisposing condition to myxomas. When you remove those, because you expect them perhaps to have a recurrence, they found that 9 out of their 11 non-Carney's patients recurred in exactly the same location. Interestingly, if you look at the recurrence risk, you would have expected that a Carney's patient would recur fairly quickly, but in this particular case, one of them took 8.8 years. Interestingly, the 12-year-old at the very top had a small tumor to start, and within 1 year, it had grown to 5.6 by 2.6 centimeters, quite a lot larger than actually the initial one. So they didn't tell us, because it probably was very hard to find, whether these were shaved or cut at the stalk, but it begs the question of whether or not there's a margin problem. When they looked at their univariate model predicting freedom from recurrence, and they couldn't do a multivariate because they didn't have enough patients at 194 patients, again, over 56 years, they found that young people recurred more often. When they had a tumor in the ventricle, it recurred more often. The smaller tumors, believe it or not, recurred more often. And for some reason, men recurred more often, but resection with the endocardial button was also a risk factor. So again, I could not understand from reading their paper. Perhaps if somebody reads it, they'll be able to understand better than I. But this begs to the question of whether or not it is a margin issue that caused the problem. especially when you look at something like the ventricle, where it has 7 times the hazard ratio, and the endocardial button has 4.9. The other ones you may say are pretty close to 1. It may be an error in terms of small numbers, but the other two clearly are quite interesting. Some people, and you'll see this in some papers, especially with the minimally invasive portions, minimally invasive operations, ablate the base of the tumor margin, the base of the tumor bed. And they do this to try to prevent recurrence. And in this particular case, the authors have used cryoablation. So when authors are talking about cryoablating the tumor bed without much in terms of examination or discussion about why it's happening, you have to wonder whether they've just plucked the tumor off of the heart and left the tumor bed there with viable tumor on its base. So when you're talking about that sort of things, you have to wonder whether or not they're doing the proper tumor operation. So recurrence happens at 0 to 6%, and it may be very late, but it's often in the same location. And we have to wonder whether it's related to resection margin more than the method of operation. I don't necessarily think that the minimally invasive portion is perhaps worse than the open operation, as long as they do the proper tumor operation. Now, you've noticed that the large series are only 200 or even less than 200, and this may take many, many years. And multivariate analysis is difficult because the multivariate predictors are hard to determine due to the small numbers. So it's hard to make a multivariate analysis when you only have 150 or 160 or even 200 patients. You need many, many more than that to make a diagnosis. Those are some concepts, but one of the other things that we have to concern ourselves with, oh, it's not working, that's unfortunate, is what is the actual tumor that you're going after. I don't know why this is not working, but it's not. But this would have shown you one sort of solid kind of tumor, and this one has some openings inside of the tumor itself. And when you're going to do a minimally invasive operation, you have to try to determine whether or not this is a malignancy. And remember, the cardiac tumor resections for minimally invasive all mention either myxoma or they mention benign disease. The problem sometimes is trying to figure out whether this is a benign or malignant lesion. These particular ones, the top one happens to be in the right chamber. So it's an unusual tumor. And one of my edicts is always a myxoma in an abnormal location may not be a myxoma. So you have to be careful. And the question is whether you do this minimally invasively or not. So you really have to have a diagnosis. Here's a patient. What kind of tumor is this? They've decided to do this minimally invasively, and they found this particular kind of tumor. Now, I don't see a resection margin unless this happens to be the resection margin here. It's hard to determine because they haven't shown the whole thing, but they've shown the fact that the tumor is quite large compared to the opening. And my question is, what should be done sometimes is not what can be done. What should be done versus what can be done sometimes turns into what can be done, not what should be done. And that's where we have to be a little bit careful, because once you've made the resection, you've made the resection. And if you get the diagnosis wrong, the person suffers because they had a minimally invasive operation. Even if you get the diagnosis correct, you may predispose the person to recurrence. Remember, most of them recur in the same spot because the tumor portion of the operation doesn't meet the tumor resection requirements, and that is of an adequate margin. Unfortunately, for myxomas, we don't know what the adequate margin is, whether it's 0.5 millimeter, 2 millimeters, 3 millimeters, we really don't know. I suspect it's very small. So let's move on now to fibroelastoma. I hope this works this time, and it doesn't. It doesn't. This was the same paper, and it showed 2 different lesions, and the both were fibroelastomas, even though they look like myxomas or perhaps something more solid. This will not play either. I'm sorry about that. I don't know why. This shows a fibroelastoma on the aortic valve, but you can see on this aortic valve in a 3D reconstruction, there are lesions in all three cusps. Now, this particular person I've been following for over 10 years. And this particular individual has refused to have an operation because he or she feels well and wonders whether they will have benefit from this. They also are afraid of losing their valve and don't want a biological valve. Those were our only two slides that had video, so hopefully it's going to be fine from now on. Now, there are a few large series. This particular series is a series of 725 cases. It is the biggest series in the world. However, it's a meta-analysis of multiple smaller papers. 209 patients were diagnosed at autopsy. So this is a combination of clinical and autopsy-related patients. Only 9 patients were found at cardiac surgery. 120 patients had a stroke, and 77 patients presented with angina or a myocardial infarction for a total of 11% of the overall group. So therefore, there was potentially a 27% embolization risk compared to about 20 or 30% risk for myxoma. So they're about the same risk of embolization as a myxoma as a presenting feature. In 517 patients, the sex was unknown, not known. As you can see here, fibroelastomas occur in all age groups. Here's less than 10 years of age. And as expected, as a person gets older, they are more common. The most common valves are the aortic valve, the mitral valve, tricuspid valve, and the pulmonary valve. In other words, the valves of the heart. But a percentage of them, and a good percentage of them, are non-valvular, usually found in the ventricles or the atria. This is another paper looking at fibroelastomas. They found the valves were in 77%, with the most common being the aortic, followed by the mitral valve. And on the aortic valve, 2 or more cusps, just like in my patient that I've been following for so many years, have 2 or more cusps involved. So the most common thing is not to have a single fibroelastoma, but multiple fibroelastomas. The cardiac chambers in this particular paper were affected in 30 patients. This was a surgical series, not an echocardiographic series. The most common chamber that they resected was inside the ventricle on the left side. So when should an operation be offered for these individuals? When should you operate on a person who has a fibroelastoma? This was discussed in a paper from the Mayo Clinic. Over a 15-year period, they amassed 511 patients. How did they find the patients? They went through 575,000 echoes to find 511 patients for a rate of less than 0.1%. I can imagine the person looking through 575,000 echoes, and hopefully they had some AI helping them with respect to getting the diagnosis. Anyway, they broke it up into 2 groups. The first group had an operation, 185 of them had an operation, and this is, as far as I could see, the biggest series of operated fibroelastomas in the literature. And the second group were people who didn't have an operation. Now, it was a poorly defined group in the paper, but for one reason or another, they did not have an operation, but they were able to find out what they did and were able to follow them in the long term. Back in group 1, those people who had an operation, there were 2 types of operations that were performed. One was where the fibroelastoma was the primary indication for the operation. That was about half of the group. And the second one was the fibroelastoma was removed at another cardiac operation. So in other words, it was an incidental finding. The patient had an operation for another procedure, and while they were in there, they removed the fibroelastoma. Again, about half of them. If you remember before, in the first series I showed you, the group of individuals that had found it operation, that was the 725 patients, was only 9 out of the 725 patients. So this group, again, it's a surgical group, not an overall group, including pathology specimens, showed quite a bigger number of patients who had a fibroelastoma that resected at the time of another cardiac procedure. They found that there were different reasons for operating on them. Nobody had a risk factor for stroke, but neurologic events were overwhelmingly the number, about half of them in the first group. In other words, the group that had as a primary indication the fibroelastoma. They had less people who were symptomatic and less people had chest pain, as you'd expect. Now, the chest pain may be coronary disease, but the Group 1A, those 94 patients did not have any coronary bypass. The only thing that they had was the fibroelastoma in their heart. If they had another reason for going in, they were in Group 1B. In other words, those people that they had the fibroelastoma resected as a secondary, not as a primary reason for having the operation. So perhaps this chest pain was intermittent occlusion of the coronary ostium. Perhaps it was microemboli into the coronary arteries. It's hard to determine, but the primary reason for the person in Group 1A to have an operation was neurologic events. Systemic emboli occur occasionally, but not very often, and syncope is equal in both groups. Were the size of the tumors different for those people who had a stroke or a neurologic event, not necessarily a stroke, for those people who had a neurologic event compared to those who didn't? Well, the answer is no. Whether you were in Group 1, in other words, you had an operation, or whether you were in Group 2, the size of the tumors was the same whether they had a neurologic event or not. So the size of the neurologic event, the size of the tumor did not predict neurological events, either preoperatively in those people who had an operation or subsequently in those people who were found to have a fibroelastoma. This shows the size of the fibroelastoma in their operated patients. The aortic and mitral, you saw smaller tumors than the tricuspid, pulmonary, and the right side. However, the non-valvular left-sided tumors were bigger than the aortic and mitral lesions. So we find that the left-sided lesions had operations on smaller tumors. Remember, these are patients that were selected for an operation. However, it did not select these, and they did not in the paper determine whether or not the tumors in those who had a primary reason for resection were any different in size than those who had an operation for another reason. In this particular group of these 511 operated patients, and 59% were on the aortic. Again, these are in groups 1 and 2 combined. Mitral was 13, tricuspid was 4, pulmonic was 4, and the myocardium was 22%. 23% of the overall group had valve problems, but only one was related to the papillary fibroelastoma. So papillary fibroelastoma does not cause valvular disease. If it does, it's very rare. You can see the size of the non-valvular right tumors was 22 millimeters compared to 8 millimeters in the aortic valves, and even on the pulmonic valve is twice as large. Once you have a papillary fibroelastoma diagnosed, you have recurrent neurologic events later on. Well, there's an interesting answer to this. It depends on what your comorbid conditions are. If you were in Group 1A, the 5-year follow-up and 1-year follow-up was equal to the expected numbers. So the answer is, if you have a fibroelastoma resected as the primary reason for having your operations, the subsequent stroke risk is very, very low. And really it was equal to the expected stroke risk for a general population. However, if you had a cardiac operation, in other words, another comorbid cardiac indication for an operation, then your stroke risk was higher than the expected. The observed was 8 strokes, and the expected was 2.4, giving a statistically increased risk of stroke in those patients who had an operation for some other reason and a myxoma was removed at the same time. Now, it doesn't say what the cause of the stroke was, but presumably the people would have had higher risk factors for stroke in that group themselves. The Group 2 patients, the ones who were observed, and again, we don't know why they were observed, they also had a higher than expected. They expected 8.4, and they found to have 29. So if you have comorbid conditions, chances are you're going to have an increased risk of stroke. But if the only reason for having your procedure is the fibroelastoma, then you've reduced the risk of stroke, perhaps, because remember, half of those had strokes and half did not, but you've probably reduced the risk of stroke in the future in those patients. They looked at their 5-year neurologic event rate in those people who had warfarin, aspirin, or nothing, and they found that there was absolutely no difference in the number of future strokes related to anticoagulation. And in other words, the warfarin and the aspirin did nothing in terms of preventing stroke compared to no treatment at all. So it seems as though there's no effect by anticoagulation, although people are very commonly anticoagulated. So the fibroelastoma category, the Mayo group suggests that an operation be performed for all left-sided lesions, regardless of size, due to the excellent surgical results. Again, especially if it's a primary indication for the procedure. If it's a secondary indication procedure, as with every secondary indication for a cardiac surgery, if it's there, you should remove it. But as a primary cause, you should remove it because there are excellent surgical results. A very low valve replacement risk. I didn't talk about it, but they recommend to shave it off unless there are too many to shave off, in which case the valve should be changed. And there's a lower long-term stroke risk. They think presumably because you've removed the stroke. Remember, half of those people presented with a stroke, and theoretically, half of them would have a stroke in the future. No randomized trial has been performed. I don't know whether one would. Anticoagulation did not prevent neurological events. And the question is when to intervene on the right-sided lesions. Remember, we saw a 2-centimeter lesion on the right side. If you see a 1 centimeter, do you watch it, let it grow? What it is, what to do. I suspect it's related to the comorbid condition of the patients and how small or how obstructive it is. Remember, fibroelastomas rarely cause abnormalities of the valves. Let's talk about the pediatric age group. Not too many people know about pediatric cardiac tumors. Here's a paper, again out of China, showing a number of patients. This was presented in 2017, 166 pediatric tumors, a very large paper. And they found that the most common tumors were rhabdomyoma, fibroma, and there's our friend Myxoma, or perhaps enemy. They did find a scattering of malignant tumors, either primary or metastatic. But I wanted to point out that the age of these individuals vary based on what the pathology is. Rhabdomyomas occur at the median age of 4 months. Fibromas, median age of 9 months, in other words, infants. And myxomas are higher level. They're 10 years of age was the median age. Mortality did occur in the infants, mostly in the did occur in pediatric age group, mostly in the infants, usually related to congestive heart failure or recurrent arrhythmias. The mortality that occurred in the primary malignancy group was obviously late, but the postoperative mortality was there for the early group, and once they passed the perioperative period, the mortality rate was very low. Sometimes these tumors prevent flow through the valve. They perform echoes in these people, and many times for these infants, they find it in a prenatal echo or ultrasound. And the age at the postnatal diagnosis for those patients in whom an obstruction to cardiac flow is present is only 4 days. And it makes sense because if a child has a large tumor in the heart that's obstructing the outflow tract, they're going to present it very, very early, compared to those who do not have an outflow tract, where the presentation was at 75 days. So it's either at 1 week or 2 or 3 months if there's a tumor in infancy. As I mentioned before, most of these patients had rhabdomyomas, and rhabdomyomas are associated a little bit more often with obstruction, but even the non-obstructive type is very frequent. There's documented diagnosis of tubular sclerosis. Tuberous sclerosis is a genetic defect predisposing to multiple tumors throughout the body. So many of these babies and children are diagnosed with tubular sclerosis, either in themselves or a family history. That's pretty prevalent when you talk about pediatric tumors and review the literature on them. The gradient, again, is dependent on where the tumor is. Those people who have a high gradient tend to have tumors that affect the chambers themselves, either one side or both sides. If the low gradient is there, you can be pretty sure that the tumor involves the interventricular septum. So the interventricular septum lesions tend not to have a gradient, and the free wall tumors or the interchamber tumors that are not affecting the interventricular septum tend to be associated with a high gradient. What's the strategy for long-term outcome? Well, operations are undertaken for symptoms, obstruction, or arrhythmias. This is from a paper over a period of 37 years and discussed only 47 patients. So a little bit more than 1 patient per year, but through this, they were able to make these recommendations. Operations are undertaken for symptoms, obstruction, and arrhythmias. Arrhythmias are most commonly related to fibromas. Myxomas in the infants or children are equally on the left and right side. Remember from the early slides in myxoma, the myxomas in the adults are overwhelmingly found in the left side. In the pediatric age group, they're equal on both left and right sides. Deaths occurred in the infants, usually from severe left ventricular failure or recurrent ventricular arrhythmias. And when it does occur, it occurs in the perioperative period. Interestingly, unlike the adult or the malignant tumors, there was no progression of the partly resected tumors. So if you go in for a tumor of a child and you can only resect some of the fibroma, is it worthwhile? Well, the answer is yes, because there was no progression of the partly resected tumors. And in fact, regression of rhabdomyomas occurred over a 4-year period. And so there is some regression of some of these tumors, specifically the rhabdomyomas. Now, I don't know whether it's a regression of the tumor or whether or not the tumor stays the same size, but the heart grows, so it apparently looks as though it's regressed. But certainly the rhabdomyomas are a group of individuals that if they don't cause obstruction, they may be watched. Again, I have to comment the fact that it took a long time and the numbers are really quite small. This is a large group of 28 studies. This is a meta-analysis again. It's 745 pediatric tumors. And it shows what we were just talking about. Rhabdomyomas and fibromas and perhaps teratomas occur in the very young. And very young means a fetal or less than a year of age. And as you get older, it's hard to call a 10-year-old old, but they get more of the adult tumors, the myxomas and the malignant tumors. There is a tumor recurrence. It's very low in the benign tumors. Remember, I said that the rhabdomyomas, although they can recur, they sometimes regress. Fibromas can recur, but very infrequently. Teratomas and myxomas. There's that number there, 4.9% myxoma recurrence, roughly equal or not out of keeping with those in the adults. Malignant tumors, as expected, do recur, but not nearly as often as they do in adults. The malignant tumors, let's look at that a little bit. The malignant tumor in a child has a better outcome than the malignant tumor in the adult. Green is the adults and blue is in the children. And the question is, why is that? Well, when you look at the type of tumors, they're dealing with some sarcomas, a rhabdomyosarcoma. They deal with teratoma, Wilms tumors, and pleuropulmonary blastoma in this particular series. So the tumors they have are a little bit different. In the adults, it's mostly a sarcoma, you'll see later on. But in the children, they have different tumors. So perhaps you would expect a different behavior and a different long-term outcome of those tumors. That's a good segue into the malignant cardiac tumor group. Malignant primary cardiac sarcoma is a bad animal. This is a paper looking at 26,000 individuals who had a sarcoma, soft tissue sarcoma or non-cardiac sarcoma, compared to patients who had a primary cardiac sarcoma, isolated primary cardiac sarcoma. They found 210 patients with a primary cardiac sarcoma, and they compared them to 24,000 non-cardiac sarcomas. And they found the median survival of the surgical group was only 6 months, and the median survival for all comers of the non-cardiac sarcomas was 93 months. So non-cardiac sarcoma is bad, but cardiac sarcoma is horrific. If we operate on these individuals, we can improve their survival from 1 month for no operation, the person who gets no operation, a median survival of 1 month with a non-surgically treated cardiac sarcoma is 1 month versus 12 months if they operate. So even with an operation, the outcome is not good, but can we make it better? Well, when you talk about cancer surgery, if there are any cancer surgeons, you can correct me if I'm wrong, but we talk about residual tumor. Residual tumor is either R0, R1, or R2. R0 means there's no microscopic tumor left behind. In other words, it's completely gone. R1 means that your resection margin was positive, but in a non-visual way. It was microscopically positive. R2 means you left gross visible tumor behind. And this particular series, again, not very big, 29 patients in a long time period, showed if you had an R1 or an R2 resection, in other words, microscopic or gross tumor left behind, the outcome was much, much worse than you had an R0 resection. In other words, I quote, got it all out with no microscopic disease. So there's a big difference between the outcome of leaving even microscopic disease versus removing it all. Here's a perfect example of a malignant tumor. This patient presented to us, previous osteosarcoma many, many years before, presented with hypotension and had a large obstructing tumor of the right ventricle. This person had to go to the operation. We did a debulking operation. I'll talk about that. That debulking means leave residual tumor. This patient underwent an R2 resection, perhaps an R1 resection, but at least an R1 resection, because there's no way in the world you're going to get microscopic clearance on a tumor of this sort at an emergency operation. So this patient had an operation. Once the person recovered, we did a pre-discharge MRI prior to chemotherapy, and we found this: 16 days, less, a little bit more than 2 weeks after the operation, the patient had at least half of the right ventricle full of tumor once again. 16 days. So left to themselves, without any adjuvant therapy, without any subsequent chemotherapy, a person who you leave residual tumor behind will die before the sternum is healed. That's a powerful statement, but unfortunately it's a true statement. And I'd read about it, and I never realized how true that is until I had this patient that I operated on. Now, I knew this person had residual tumor left behind. You can see my scissors in the bottom picture with tumor on the scissors. So there was residual tumor left behind. That's an R2 resection. But within the short time period, the tumor had almost completely recovered to where it was before we actually started. This is a paper of 551 individuals over a 40-year period, a little bit more than 40 years actually. And this is from the SEER database. There's no chemotherapy information apparently in the SEER database, I found out. There may not be any radiotherapy information on the SEER database as well. The SEER database is a registry of malignancies in the United States. They had 7.4 million total cancer cases recorded from 1973 to 2011 on this database. They found 551 cardiac tumors. Remember I said at the beginning, the problem with cardiac tumors is that they're very rare, and this shows how rare they are. They found, as we already said in some of the people, that cardiac tumors, malignant cardiac tumors, occur in all age groups. Here it shows they even have less than 4. So it shows in all age groups. Sure, it's more common in the more advanced ages. Advanced ages means 20, I'm sorry to say, for all the residents that are watching, but it affects everybody in all age groups. What are the most common types of tumors that they found? Well, the 3 most common are sarcoma, lymphoma, and mesothelioma. Mesothelioma are less common. I've been dealing with cardiac tumors for many, many years, and I've actually never seen a mesothelioma of the heart. There are sides. Tumors do take sides. If you look at the angiosarcoma group, the vast majority are in the right heart, often in the right atrium. The intimal sarcomas are left-sided tumors, and the undifferentiated sarcomas are somewhere in between. They're undifferentiated because they're advanced in their course, or we don't quite understand how to classify them. A little bit more about that later. But they do take sides. Right-sided are often angiosarcoma, and the left-sided are often either undifferentiated or intimal sarcomas. This is a paper from the French sarcoma group. They were early presenters of their data. This was from 2014. There's another large series by them. And they took a group of patients from 1977 to 2010. So again, a very long time period. In that very long time period, they found 124 patients. So that's roughly 4 patients a year into that group in all of France. Obviously underreported, because there has to be more than 4 people who come with a cardiac tumor every year in a country as large as France, but this is what we have to work with. They found the sides, the tumors did take sides here. The angiosarcomas represented 80% of the right-sided tumors, or sorry, 80% of the angiosarcomas were on the right side. The leiomyosarcomas, or the poorly differentiated sarcomas and other sarcomas, were on the left side primarily. 20% of the people presented to them with already metastatic disease, and metastatic disease affected the lungs in 37%, the liver in 29%, and the bone in 29%, as well as a smaller portion, but a significant portion found in the brain. When you're working somebody up with a sarcoma of the heart, or you think it's a sarcoma of the heart, always look at the brain, because it affects the brain more commonly than people think that it does. Even if it's not supposed to go to the brain because it's a right-sided tumor, why should it go to the brain? Always check the brain when you're working a person up. Of those 80% who presented as isolated cardiac tumors, eventual metastatic disease occurred in the lungs most often and in the brain second. So the brain is a player, unfortunately, in sarcomas of the heart, or malignant cardiac tumors of the heart. When it did recur, when it did metastasize, it happened an average of about 11 months later in those other lesions, in those other areas. And if it was a local recurrence, again, it happened roughly at the same time at 10 months. This is a busy slide, but I'll go through it. There were those patients who had non-metastatic disease at the time of diagnosis, 100 of them, and 24 of them had metastatic disease. R0 resection, in other words, they were able to get the whole thing out without microscopic disease left behind, is only 10 of the 100 patients, so 10%. And they had an unknown number in 14%, but most of them had either an R1 microscopic resection positive or R2 gross tumor left behind. Interestingly, in their series, they had 5 patients who had transplantation, and I found quite interesting that they transplanted somebody who had already metastatic disease at the time of the diagnosis. Most people had combination chemotherapy, but if you had metastatic disease, it was more likely that you had monotherapy for your chemotherapy as well. Surgery and chemotherapy, or chemotherapy alone, were the most common treatments. And if you had metastatic disease, a multimodality therapy, including surgery and radiotherapy, chemotherapy and radiotherapy, or surgery in the 3 were not performed in that group of individuals. Let's stop back and look at those transplants. They had 5 people. This is another group of individuals who looked at a bigger number of people. They reported their series, again, out of China in 2016, and they looked at their survival of the patients that they transplanted. In total, they had 30 people who survived, and they had a good series of people they did transplants on. Now, they looked at the chemotherapy effect, and the chemotherapy effect showed if they had neoadjuvant chemotherapy, there was no effect in terms of the survival. This is not the number of people. This is this average survival. There's the number there, 18 and 11, 34 and 27. But the average number of people that survived, the average lifespan, whether they had neoadjuvant chemotherapy or adjuvant chemotherapy, in other words, had the chemotherapy and then had their transplant, or had their transplant and then had chemotherapy, there was no difference in the outcome of those individuals compared to those who did not have chemotherapy. So there was no chemotherapy effect. When you look at angiosarcoma, those right-sided tumors, whether you had a transplant or whether you had no transplant, there was absolutely no difference in survival for a person who had a transplant compared to those who did not have a transplant if your diagnosis was angiosarcoma. If you had a non-angiosarcoma diagnosis, the survival was better than those angiosarcomas, but much worse than the standard transplant survival. So transplant for angiosarcoma, it will not work at all. Transplant for a non-angiosarcoma may have an effect, but not nearly as good of an effect as if the person didn't have a cancer. This is a paper where they looked at 442 patients, again, over 42 years using the SEER database. So about 10 patients per year in this database. And they broke it up into an early time and a late time to see whether or not from 1973 to 2005, whether the outcome for treatment for sarcoma changed. And the answer is no, it didn't change at all. There was no difference, no advances in the surgery or treatment for angiosarcoma between these two time periods occurred. They looked at the group, that was overall, they looked at the group to see whether or not operations made a difference for this, and in fact, they did make a difference. Remember, the overall survival was no difference in the early and late time period. However, if you broke it down as to whether the patients received an operation or not, there was a benefit that probably went away by 2 or 3 years. If you added some form of treatment, in this particular case, chemotherapy, again, this doesn't tell us whether or not the chemotherapy happened before or afterwards, and chemotherapy apparently in the SEERS database is poorly represented or poorly followed. But if you added some chemotherapy to this individual, you do improve their early but not late survival. Again, the benefit happens to stop at around 2 years. Another paper looking at 617 patients in a 14-year period presented to this year, or not this year, 2021, showed that if you had any therapy, chemotherapy, radiotherapy, the combination, etc., it again added to your early survival over the first 2 years, but then it equaled after that. So it has an early signal, but no late signal. The first slide on the left shows the very poor outcome if there's no treatment and if there's non-surgical treatment. In other words, isolated radiotherapy or isolated chemotherapy has a benefit over nothing, but the best long-term outcome is with an operation, and even better than that is an operation associated with one form of therapy. Still a very poor outcome. Still, there's a long-term equalization of all patients, whether they've had adjunct therapy or even any therapy. So can we improve upon these outcomes? What can we do to get these outcomes better? Because certainly they're not very good. Well, if you find a tumor by accident that's less than 3 centimeters, you're lucky because the outcome is better. Again, not very good, but it's better. So if you could turn back the clock and regress the tumor, then we can get a better outcome. Perhaps if you give chemotherapy or radiotherapy before and get the tumor smaller, you may have a better outcome. But clearly, the inflection point seems to be around 3 centimeters. A lot of these articles talk about different clinical factors that affect survival. And in this particular paper of the 442 patients, incidentally, they included 27 patients less than 20 years of age. They found that surgery or chemotherapy, or possibly the combination of the two, improved survival. They also found, as we spoke about earlier, that younger age is a better outcome. They did find this in people operated less than 45 years of age versus greater than 45 years of age. And it may be related to comorbid conditions of the individual, but it may also be reflected in that this particular paper, for instance, had a number of people who are less than 20 years of age, and the diagnoses in those younger people may be different, and they may have a different behavior. But let's look at surgery and chemotherapy as well. Dr. Reardon, he's part of this seminar or conference. He and his group have been instrumental in pushing the field of cardiac tumor treatments throughout the world. They're a very, very strong group. I think they're the #1 group in the world for cardiac tumor treatment and diagnosis. They early on in 2009 reported on a series of 27 patients, and they noticed one thing. They noticed 2 things. One, 2 out of 8 left-sided tumors, they looked at tumors whether they're right and left-sided. 2 out of the 8 had an R0, sorry, there should be R0. 2 out of the 8 had an R0 resection, but 13 of 19 right-sided tumors had an R0. And they found that R0 patients live longer. So what they found is it's more common to get an R0, or in other words, complete resection on the right side than it is on the left side. And they also found that the R0 patients live longer. That was in 2009, and that was 27 patients. And this is when they used the combination of surgery and chemotherapy and radiotherapy, all the things that they had available to them. They found the right-sided tumors were more likely to have an R0 resection. The French sarcoma group found the same sort of thing. The median survival for an R0 patient was 38 months. but for an R1 or an R2 was 18 months. Remember, the R1 and the R2 may be exactly the same. There aren't too many articles in the paper that we can find that show there's a difference between R1 and R2 survival. Transplanted patients in their French sarcoma group had a median survival of 27 months. Very little was discussed about the transplanted patients and diagnosis, et cetera, but they seem to have an intermediate survival. Dr. Reardon's group, again, examined some patients. Subsequently, in 2017, they reported on 44 patients of right-sided sarcomas treated by neoadjuvant chemotherapy in 32 patients and non-neoadjuvant therapy in the remaining 12 patients. And what they were able to find is the neoadjuvant versus no therapy had a slight improvement in survival. Survival for those who did not have neoadjuvant chemotherapy was 9.5 months versus those who had the neoadjuvant therapy was 20 months. But what they found as well is they confirmed that the R0 resection, as all the studies have shown, is a great thing. They found that they had an improved median survival from 9 months without with an R1 or an R2, and they found a survival of 53 months for those who had an R0. This was significantly positive. They found when a person had neoadjuvant chemotherapy, R0 was achieved in 47% versus only 33% when no adjuvant chemotherapy was given. And that led them to suggest that we should give neoadjuvant therapy to all patients who come with a cardiac sarcoma. And I think this paper is a landmark paper in moving treatment towards that. So what's the rationale for neoadjuvant therapy? Perhaps it gives more R0 resections. Now, it may be a little bit false to say that. Dr. Reardon, if he's listening, I'm happy to hear your comments about this. But this may not necessarily be that neoadjuvant chemotherapy is allowing more R0 resections. It may be center or surgical experience or aggressiveness. In other words, those centers that go to the trouble of getting a preoperative diagnosis, giving the person neoadjuvant chemotherapy, they probably are a more experienced center and they have more aggressive surgeons who are able to do this more often and therefore have a bigger experience. That may be one reason, but it may also pre-select those with aggressive disease. In other words, you have a person, you take a biopsy of their cardiac tumor, you give them neoadjuvant therapy, but during the neoadjuvant therapy, they develop metastatic disease, or the primary tumor grows, or the metastatic tumor grows, something grows, and they never come to surgery. So the outcome is better, not because it caused more R0 resections, because it eliminated those people who should never come to an operation. So it's hard to say whether neoadjuvant chemotherapy is useful or not. Unfortunately, they're small numbers. Remember, Dr. Reardon's paper, in whom we used to recommend neoadjuvant therapy, only had 44 patients over a number of years. Well, let's look at something else. Let's look at the diagnosis. This is a paper examining the diagnosis and what we use for diagnosis. The most common thing you'll get when you get a biopsy is histology. We send a piece off to the pathologist and we wait for the pathologic response. Yes, this is a sarcoma. Well, this particular case shows 4 different intimal sarcomas. They're left-sided tumors, 4 different intimal sarcomas. Are these the same? 3 of them sort of look the same. The one on the left lower, the very bright red one, to me looks totally different than the other ones. Will they behave equally, these 4 different patients? And is the survival different amongst these 4 patients, or is it similar? I find it hard to believe that they will behave the same. And I find it hard to believe that the survival will be similar in these 4 patients, but an intimal sarcoma is an intimal sarcoma, right? Perhaps they will. Well, let's look at it a little bit more deeply. When you use immunohistochemistry, and what they use when they use immunohistochemistry is they use an antibody specific to a certain antigen on the surface of the cell or a protein inside the cell. So this is MDM2, which is one of the proteins that they look for. And the one on the left is strongly staining for that protein. And the one on the right is weakly staining for it. So these 2 tumors, even though they're both intimal sarcomas, may react differently. And that's where immunohistochemistry helps us along. This is something called FISH. FISH is fluorescence in situ hybridization. And what they do is they look for specific DNA sequences on chromosome using a DNA probe that has a fluorescent stain on it. And this again is an MDM2 gene organized in small clusters, as it says underneath there. So now we're getting not only at proteins, we're getting at the DNA structures. And so this is a great way of perhaps moving the whole field forward. Now what we can do is we can get a histological stain, yes, but we will get more than the histological stain. We'll get the immunohistochemical determination of what this tumor is. And you can see if you look across the top board, it's not a 0 or 1, although some of them are 100%, but small numbers. But it's sort of a, yeah, this is sort of more common in this is sort of more common in this, and they will give us a immunohistochemistry profile of this tumor. When they look more deeply, you'll see that tumors are very variant in terms of what genes they may or may not express. So what we're getting now is we're getting a histological as well as a different kind of a diagnosis. This would be what a pathology specimen looks like today. This group of individuals examined a number of cardiac tumors in 2014, and they looked at the histologic type of primary cardiac sarcoma when they had no stain, nothing other than histological stain, and after they used more advanced techniques. And they found that there was a big difference. Intimal sarcoma initially was 6 patients, and after they looked at it, they reclassified a lot of those tumors as an intimal sarcoma. And you can look down the list and see how the reclassification changed after they had a little bit more information about what they were dealing with. So now that we're able to better classify the tumors, we can figure out a little bit better what we're dealing with and compare apples to apples. We find for malignant disease that it's very, very lethal, especially primary cardiac sarcomas are much more lethal than all the other tumors outside the heart. Therapy, any therapy added to surgery provides better early results. And it's unknown whether neoadjuvant therapy is beneficial, even though we do it. It's a standard of care now. R0 is always the goal of the resection, and better quantification may help for a more appropriate classification. So for instance, when we're testing a specific chemotherapeutic agent on an intimal sarcoma, are they really intimal sarcomas, or are there other kinds of sarcomas thrown in there? We saw the undifferentiated sarcomas. Well, now that we know that we're only dealing with intimal sarcomas, based on the more immunohistochemical studies or any of the advanced methods of diagnosis, maybe we'll have a better understanding of these tumors and better able to compare different types of chemotherapeutic agents. Now that we're able to stain for these things and able to target even at the DNA level, we have new targets for future treatments. I think this is very, very exciting and fit for study. Unfortunately, all of these tumor numbers reported in the literature by these different varying authors all have small numbers that have been amassed over a great number of years, and that's the biggest problem. But it's big inroads in terms of quantification and targets for future treatments. So what is known and unknown? Well, more is unknown than is known. Where are the centers of excellence? If you have a child who has a cardiac tumor, as long as they're not an extremis, where do you send that child? The numbers, even for benign disease, truly are small. It would be very beneficial to have international collaboration. So instead of having 200 tumors over 40 years one place, 120 tumors over 20 years in another place, we'll have multiple hundreds or even thousands in 1 year. Individual countries don't even provide enough patients. We need the whole world together. And so therefore it won't take somebody's whole career to understudy a group of tumors, because even though we're studying them, we're really understudying them because the numbers are so limited. And it would allow for more specialized care if we had a large number of tumors being taken care of in the whole world at once. We could develop a specialty of cardiac tumors. To that end, I'm going to talk a little bit more about the International Registry to Assess Cardiac Tumors. It's going to be spoken about by subsequent speakers. But this is the steering committee for the International Registry to Assess Cardiac Tumors, or the INTERACT project. And you can see it's a global initiative. We have people involved in Canada, United States, South America, Africa, Europe, Asia, and Australia. It really is a global initiative to try to answer some of these questions and get the whole world together to advance the knowledge and understanding of cardiac tumors. And that's the end of my talk. Matt, could we have the are there any questions by anybody?
Dr. Cusimano, do you have the chat open on your screen? There's a couple of questions.
Yes, I do.
Okay, perfect.
Interestingly, I spoke about the minimally invasive myxoma paper, and we actually had the author, Dr. Bianchi, is online on the tumor. I'm very, very happy to hear you that you're on the tumor. Could we please have your comment and your question? He wanted to expand on that, and it's very, very nice to actually have the author talk about that. Are you still online?
Yeah, I'm online. Can you hear me?
Yes, it's very, very nice to meet you online. I'm very, very happy to see this.
It's a real pleasure to attend this tremendous meeting. I'd like to stress the point about the minimal invasive surgery, and I'm glad you cited our paper. I have to say that maybe for the sake of brevity, the methods of resection was not the same that we reported in the paper. We did not shave. We reported to take out the tumor along with a layer of endocardium, and in some patients we had to resect the interatrial septum too and patch it. Minimal invasive actually is not a limit for which is the common surgery for myxomas. Even in case you have to resect also the interatrial septum and then patch it afterwards. And the only patient that we had a recurrent was 24 months later. The median follow-up time was 59 months in the whole case series. And also, after you cited the paper about from the Mayo Clinic group, and also in their experience, they report there is no association about recurrency if they resected only the tumor stalk or also the endocardial resection. This is another clarification I'd like to make.
Yeah, I think that's really important. The problem is that we don't know how much margin to take. And what I'm trying to say is I don't think it's necessarily the method of the operation. I'm not trying to say that the method of minimally invasive operation is wrong. I'm saying that we don't know whether or not minimally invasive or even open, how much tumor resection to take, and we don't understand why people recur. And it points out the fact that it might be a resection portion. I mean, when you talk about shaving, what you're talking about is shaving means remove some of the endocardium, so you have an R0 resection of your myxomas. And I think that's what we all have to get. When people talk about ablating the bed, you can be pretty sure that they're not taking any endocardium along with the tumor. So I'm saying that it matters that you do a proper tumor operation, not necessarily how you get into the heart to do that tumor operation. One of the problems, and I'd like to ask you, one of the problems is trying to determine beforehand what the pathology is. For instance, I'm really happy that you're online because you're a minimally invasive surgeon, a surgical group there, is how you determine what the pathology is beforehand. Is by echo, by location, I can understand that. And would you resect something that you are concerned that it may not necessarily be a benign tumor by minimally invasive methods?
Thank you for the question, because we also had experience of an unexpected finding. First of all, for the myxoma, we do transesophageal echocardiography. If the patient does not present in emergency, just like a tumor plop with obstruction symptoms. We have time to perform MRI that usually characterize very well these kind of masses. And one time happened that we went through this minimal invasive operation for obstructive symptoms from a right atrial mass that when we get into and then we resected, it was not like a myxoma. We raised the concern immediately after. And then at histology, and we also published that and is cited in the same paper, it came out that it was a colonic cancer metastasis to the right interatrial septum. So this patient underwent an R1 resection, but eventually 3 months later, he had recurrent symptoms, and also the PET scan revealed captation on the atrium. It was not complete resection. So if we are very sure that is a myxoma, we'll go for minimally invasive. Otherwise, we agree that sternotomy approach can also control for unexpected findings in the operating theater, or if we are unsure of the extension to the surrounding structures that can potentially can be resected or not, or have complications.
Yeah, I think it shows a very mature group of individuals doing that in your center. You're a very mature center, and I congratulate you on your results. It's a very, very nice and coincidental that I chose all the papers about minimally invasive. I chose yours, and you're here today. So thank you very much for your comments.
Very good.
We have some other questions. Dr. Rogala is one of our interventional radiologists. He's one of the world leaders in getting percutaneous biopsies of the heart. One of the problems, as you saw, is that there are very few R0 resections for left-sided tumors, and that may be because there's very few preoperative diagnoses. And Dr. Rogala, with his efforts of doing percutaneous biopsies, has moved the needle forward to try to get more and more biopsies where previously we weren't able to get biopsies. So it's great. He's asked, have you seen differences between biopsy post-resection pathology given the potential heterogeneity of the tumors? In general, when we get the biopsies, your biopsies are very, very good. And we're usually pretty good. The most commonly misdiagnosed tumor is the myxoma. And the myxoma are most likely on the left side. If you were to speak to Dr. Reardon and the group down in Texas, who get people sent from all over the country for their sarcomas, and they see more than I do, a good number of their sarcomas are myxomas that were misdiagnosed. And we don't usually get a biopsy of a myxoma because they're left-sided. People see them on the intraatrial septum, they hit the myxoma and they go in. But whenever they get a biopsy, it's very unusual to have a different diagnosis at the final pathology than it is at your biopsy. Somebody, Dr. Lestuzzi from Rome, she's also a member of the Interact group. She's asking, do you think that right-sided fibroelastomas, there may be room for transvenous interventions? You know, that's a very important question to ask, because I've gone and I've done some minimally invasive, not as many as the group that just spoke, Dr. Bianchi's group, but for a fibroelastoma, if you're pretty certain it's a fibroelastoma, you know, they have no uptake on the imaging. Dr. Rogala can talk perhaps about the difference between a fibroelastoma and a solid tumor. Fibroelastomas are hard to see on MRI or CT scan because they're so mobile. But I have had reports of fibroelastomas with minimal uptake of contrast, and it can be misleading sometimes. But you know, there are ways to remove things, say with a snare or something like that, if you see a good stock. And we have yet to see those published in the literature, but it is a possibility of happening. It doesn't really matter if the biopsy comes back as something else, as long as they can grab onto it and it doesn't metastasize. A transvenous, say, stalk or snare removal, as they would for colon cancer and colon adenomas, would be, I think, personally quite appropriate for the heart, because it's a biopsy, it's a transvenous biopsy. In this particular case, if it comes back as a fibroelastoma, you can watch the lesion, you've prevented an operation. If it comes back as a malignancy, it's your biopsy. If it comes back as a myxoma, you can consider going back in and removing the stalk or even watching it. If it's on the right side, it doesn't matter as much. It's not as much of a problem on the right side of tumors as long as they're not malignant, because the downstream location of the metastases is going to be into the lungs. And if it's a benign metastasis into the lung, it doesn't matter so much. There are two questions about, and please, anybody has any comments, please pipe in as well. There are two comments about transplantation. Some people say, do you have any experience with auto transplant? And two different people asked that question. And yes, we do have some experience with auto transplant at Toronto, and it was really pioneered by Dr. Michael Reardon. Again, every time you hear an important paper, Michael Reardon is behind it. And it shows you what a giant he is in the world of cardiac tumor in the world. We do have some experience with auto transplantation. It's for places. Auto transplantation, again, is just an incision. For those surgeons out there, you know what I'm talking about. How do you incise the heart to get at a specific tumor? An auto transplant is a method of cutting into the heart in order to gain a window into where the tumor is. So if the tumor is in a very difficult to remove location, for instance, at the base of the heart, at the posterior wall or the anterior wall of the left atrium, by dividing the superior vena cava, pulmonary artery, and aorta. Now, we usually leave the inferior vena cava alone. There's technical reasons for that. We've just gotten accepted a paper about auto transplantation in Journal of Thoracic and Cardiovascular Surgery Techniques, I think it was. But you'll be able to see that. We discussed the pros and cons of the auto transplant versus a full transplant of the heart. It's probably better to leave the inferior vena cava alone because you don't need to divide the inferior vena cava, less time doing that, less problems with reorientation of the heart. But it's really a method to get at places that are quite hard to do if you don't cut those places, don't cut those vessels. So there's nothing really too special about it. It's just to have the experience and the skill and the courage to cut across the superior vena cava, aorta, and the pulmonary artery. I think that if you're going to get into the world of cardiac tumor surgery, you have to have a lot of transplant experience. I think it's a really, really good basis for cardiac tumor surgery. So we have had experience with that.